Now, without further delay, let's begin today's event, sponsored by Progress and hosted by Health Data Management. I'd like to introduce your moderator for today, and that is Greg Slobodkin. Greg, you have the floor.
Hello, everyone. As was mentioned, I'm Greg Slobodkin, Managing Editor of Health Data Management. I'd like to welcome you to today's webinar, Reducing Patient No-Shows with HIPAA-Compliant Digital Health Experiences, which is sponsored by Progress. Today's webcast is on an important and timely topic. A growing problem for many medical practices and organizations is patient no-shows, a problem that by one estimate costs the industry $150 billion annually. Patient no-shows impact the quality of healthcare delivery and increases overall operational costs. To decrease patient no-shows, providers and practices are effectively using communication tools and solutions to automate patient scheduling to drive operational and clinical efficiency. By facilitating HIPAA-compliant digital health experiences for patients, providers can improve practice efficiency and productivity while eliminating staff time spent confirming medical appointments. In this webinar, you will learn about a case study involving the Department of Veterans Affairs that was successful in reducing patient no-shows. You will also hear about HIPAA considerations that provider organizations should be mindful of when developing patient no-show strategies. I also want to let everyone know that CE credit is being offered for this webinar. This program has been approved for up to one continuing education hour for use in fulfilling the continuing education requirements of the Certified Professional in Healthcare Information and Management Systems and Certified Associate in Healthcare Information and Management Systems. We are fortunate to have with us today two subject matter experts in the field. We have Dr. Mike Davies, Senior Medical Advisor for the Office of Veterans Access to Care. Mike is an internal medicine physician who has spent significant parts of his career as a hospitalist, VA Chief of Staff, Medical Director of a network primary care service line, as well as National Leader for Clinical Practice Guideline Implementation. In the past, he co-led the development of electronic clinical reminders, which is a key enabler in producing the Veterans Health Administration's #1 performance and quality measures. Mike has been an architect and leader for VA's medical home called PACT Implementation, and he's also established VHA's performance improvement capability called Systems Redesign and one of the nation's first healthcare engineering resources called VERX. He crafted numerous national training academies for improvement professionals, led research efforts, and published scholarly articles on topics of waiting times, consults, no-shows, and telephones in VA. Mike spent more than 12 years consulting among practices outside the VA nationally and internationally to implement same-day access and improve inpatient hospital flow. In his current VA role, Mike is leading the implementation of VHA's new electronic scheduling systems and co-leads policy, education, informatics, and oversight for access scheduling and consults, and that covers 9 million enrollees. We also have with us today Andy Reeder, who is the Associate Vice President for HIPAA Privacy and Security, and he is at Rush University Medical Center and other associated hospitals and ambulatory centers in Chicago. Andy has served Rush as Assistant Compliance Officer, HIPAA Security Officer, Director of HIPAA Privacy, and Manager of IT Risk. In his role, he provides leadership in achieving regulatory compliance around information protection requirements with major responsibilities, including response and investigation into HIPAA privacy and security incidents. He also covers HIPAA privacy and security compliance, coordination of patient privacy rights acts, as well as policy development. Andy also manages the Rush hotline, which supports all areas of Rush on a 24/7, 36 basis. Outside of Rush, Andy serves as adjunct faculty in the College of Computing and Digital Media at DePaul University, where he teaches topics on cybersecurity, privacy, as well as information assurance at the graduate and undergraduate levels. Prior to his work at Rush, Andy served as a Director of Information Security at a major regional medical facility and was a senior manager at a large professional services firm, as well as holding positions with various organizations supporting the defense and intelligence industries. And now, without further ado, I'd like to pass it along to Dr. Mike Davies.
Thank you very much, Greg, and thank you all for inviting me to participate and share with you some of the things we think we've learned in VA about no-shows. No-shows are a big deal for us. We're a large organization, 1,700 sites of care, probably 20,000 practices, about 365,000 employees over all of the continental U.S. and beyond. Our employee physicians are salaried. And so our job as an organization is to set them up in a position to be successful. And that includes giving them information about their practice, waiting times, quality, patient satisfaction, and as part of that, no-shows. Because VA's no-shows have historically been higher than we wanted, which is in the 12% range, we've had investment, I would say a lot of investment into figuring out why people no-show and how we can decrease that. So I'd like to share some of those learnings today and talk a little bit about not only what is a no-show, what do we know about them from our data, what are common patient-reported reasons for no-shows, and what strategies are we looking at to try and reduce no-shows. First of all, what's a no-show? A quote, no-show means a patient has neither kept nor canceled a scheduled appointment. Some people look at it as all the appointments that were scheduled and completed, or all the appointments that were scheduled and incomplete. Now, an important detail around definitions is when do we consider a patient a no-show? You know, some people say, well, if you don't let us know an hour before the appointment's supposed to start, we'll count you as a no-show. Other people give you an hour lead time after the appointment. So I would just say be cognizant of whatever the definition of a no-show is in your world. We tend to use the minute the appointment is scheduled to start. If you're not there the minute the appointment is scheduled to start, in our world, you're considered a no-show. We recognize that a late cancellation, somebody who cancels a few minutes before the appointment, functionally is probably a no-show because it's harder to use that time in a productive way. We're also would note that patients who cancel after the appointment or clinics that cancel appointments after the appointment functionally are no-shows. So we have had to educate and re-educate the staff saying, look, you know, a no-show is really anyone in the system that we mark as a no-show. In other words, the scheduler has gone in and labeled them a no-show, plus anybody who has a patient or a clinic cancellation after that appointment was scheduled to start. No-shows are common, as I mentioned earlier. I've seen community health centers where the no-shows are 50%. I met an OBGYN doctor one time who had a no-show rate of 90%. And it's just like, oh, my goodness, you know, why even schedule an appointment if the patient is that likely not to show? Just treat everybody, you know, as a walk-in to try and use the provider's time as productively as possible. And I know all organizations struggle with this at some points. Some organizations, you know, get frustrated, I think, probably, and threaten to charge the patient, you know, if they no-show. In our world, in the Department of Veterans Affairs, of course, we don't do that. We can't do that. And we think that there are a lot of things that we can do short of some kind of negative feedback or action with the patient. No-shows are obviously preventable. They're poor quality. They're very expensive. An appointment in our world, on average, across all specialties, is somewhere between $150 and $200. So if we fail that appointment in some way, you know, we're not using our resources wisely. And, of course, they're dissatisfying not only to the patients but also the staff. Now, I would hasten to add that early in my career, and I think this is common among my colleagues, if a patient no-showed, we'd sort of celebrate a little bit, say, all right, we got a little break in our day to do something we need to do so that we can get back to, getting the next patient on time. And in a sense, that's good for me personally as a provider. I have a little more flexibility in my day, but bad for our mission because essentially any patient appointment that no-shows, we end up scheduling again. So it's just like scheduling 2 appointments in order to complete 1 appointment. That is, if the patient shows up the second time. So it is dissatisfying and poor quality. At one point then in our journey, we decided to do a deep dive into try and understand a lot more about no-shows in the VA world. And we looked at 3 organizations, Pittsburgh, Tampa, and Houston, and looked at 7 years of appointments for those facilities, which amounted to over 25 million appointments. That covered over 500,000 individual patients. Now, a little bit about our population. As you might imagine, the VA is overwhelmingly male, 91% compared to female. And we have a lot of ways that the population varies in age. Most of our patients are in the 50 to 65 age range. And there's a little different pattern in the number of appointments males and females make. Males tend to make most of their appointments between the ages of 55 and 69, whereas women tend to come in to the doctor more between the ages of 45 and 64. And the article that's referenced at the top there goes into more of the details about the population and the age groups. We looked at appointments in primary care, mental health, specialty care medicine, rehab, and surgery, along with all the remaining ones were in an other category. And what we found was, in terms of men and women, young men tend to no-show the most. And this graph, which shows the buckets of age groups, patient age on the bottom, and the no-show rate on the y-axis on the side, shows that men in the red, between the ages of 0 and 24, we found had a 40% no-show rate overall compared to women who were about in the 34% range. You can see how that number changes over time. The older population, we tend to have a sort of a biphasic population in VA. We have a group of older veterans who tend to be Korea and Vietnam era, and then some of the younger veterans who recently are discharged, so it's an interesting spread of ages there. Another key finding, I think, of our study was the pattern of scheduling makes a difference. The longer time between when an appointment is made or created and when the appointment is actually completed predicts the chance of no-shows. And if you just think about it, in your own experience, you might say, yeah, this makes sense. If I make an appointment today for my yearly physical 1 year from now, who knows what I'm going to be doing in a year. Maybe I can make that time, maybe not. You forget about it. It tends to be, sort of out there in the ether until the appointment maybe comes and passes. But this is striking, actually, to me, and I think teaches us some things. You'll notice that even if you make the appointment the same day, there's still some of a no-show rate that's less than 0.1 or 10%. There's still some no-show rate there. And so we looked at appointments in our medical system, in our electronic medical record that were created and completed on the same day. And still some people apparently are walking out of the facility or forget about it or get tied up with something else and don't complete them. But generally, the curve knee doesn't happen until about 30 days. So if you make an appointment for any time between today and 30 days from now, we tend to have a no-show rate that's pretty predictable and under 20% until it starts to be older than 30 days. And then, as you can see, it goes up pretty dramatically. So there's a lot of discussion in my world about, how far should we open the schedule, how far in advance should we make appointments, and I think this study teaches us that appointments made within 30 days are more likely to be successful than appointments made farther out into the future. So if you're an organization that makes appointments a year in advance, then we have to have a good way of canceling and rescheduling and confirming those appointments and reminding and identifying those people that have old appointments, or we're going to suffer a large no-show rate for those particular appointments. This graph of appointment age shows it dramatically compared to new patients and established patients. Same concept. Notice that new patients have a higher chance of no-show, and their chance of no-show goes up, again, markedly after 30 days. New patients in our study were defined as any patient who hadn't been seen by that specialty in the last 2 years. That's slightly different than the CMS definition of patients who hadn't been seen in that specialty in the last 3 years. But I think the theme is the same, that new patients tend to no-show more than patients who already have an existing relationship with the clinic. Interestingly, when we looked at the different specialties, and this is one graph that shows female patients, we see that patients who are enrolled in mental health and rehab tend to no-show more than patients in other specialties. Other literature suggests that mental health appointments may fail when the patients get sicker. And so one potential response is go find them, send a case manager out there, try and figure out why they didn't show up, because it could really be an indication that they need to be seen more than you think. So in mental health, I tend to think of differently. Rehab, if a patient gets better, if your back pain gets better, you don't show up for that rehab appointment, they seem to be obviously a no-show more than the other ones. But in general, there are differences between specialties, and I just wanted to point that out. And finally, this last graph from the study that we did was pretty interesting because there's 3 moving parts on this picture here. May take a moment just to digest this. One is the no-show rate on the left, as we've seen in the other graphs, the patient age group on the bottom, and then the different colored lines are the appointment age. And so this shows very clearly that the brown line at the top, which are appointments that are more than 240 days old, meaning that they were made more than 240 days ago, those appointments are much more likely to no-show, over 50% there, compared to appointments that are made close to the time that they're completed. So those that are made 1 day or even 30 days from the time that they're completed. So when you start to combine these factors, we can really predict that young men in mental health or rehab who make appointments far in advance are more likely to no-show than they are to show. So, ding, ding, there's a group that we need to really focus in on. All right. In addition to the large sort of population work that we did to understand no-shows, we also did a large survey of our customers, almost 5,000 surveys, where we asked people questions about why they no-showed. And it was fascinating. And the results showed that there were many reasons, and we categorized them into patient reasons, systems reasons, logistics and transportation, and a large group of miscellaneous reasons. First of all, the patient factors, as you can see in this slide, number 16, were the largest bucket of reasons. Patients say they forgot, they weren't aware of their appointment, they were sick, which always surprises me as a physician. Why not come in if you're sick, right? Something unexpected came up. They had a conflicting appointment. They didn't intend to keep the appointment in the first place. They got care elsewhere but just didn't let us know. So there's a bucket of things around patients that are the biggest driver of no-shows. However, take a look at the system factors, which are almost 30%. Patients say that in some cases they weren't aware of their appointment. And we in VA used to sometimes make appointments without involving the patient, or make appointments that the patient really didn't understand very well, or refer patients to a specialty care provider and they weren't aware that they needed an appointment with a specialty care provider, because sometimes a physician would do this and after hours work and see a test result and send a consult to try and address it and couldn't get a hold of the patient or didn't get a hold of the patient. There are times when patients are admitted to the facilities, or times when the patients got their appointment rescheduled or tried to get their appointment rescheduled. Patients had a conflicting appointment at the VA, or they couldn't find us, or they couldn't park, or it was a bad day for traffic. So there are system factors there too, along with logistics and transportation factors. Traffic, as I alluded to, couldn't get a ride. The bus time didn't coordinate with the appointment time. We had a snowstorm or whatever. Interestingly, parking turns out to be a major problem, especially if the parking lot capacity is not quite enough for those patients who are in appointments right now. And if your clinics start running late, then the cars end up parking longer than you would expect, and the next group of patients don't have parking spots. So that can be a particular problem for certain places. When we did a Pareto chart of this, you can see that of the veterans who missed their appointment, the most commonly reported reason was they forgot. And if you skip past the miscellaneous group, the next most common reasons patients reported was that they were not aware of an appointment. Then transportation, weather, sick, and something else came up. So I think it's really instructive to focus on the top 2 or 3 areas when trying to improve the no-show. So what we did in VA was we said, okay, we know a lot more about this now. We are going to take what we know about those populations most likely to miss appointments, and we're also going to look at your individual no-show rate as a patient, and we're going to put together a predictive model that staff can use to go in and look at tomorrow's appointments that has the chances that someone are going to no-show listed by their name. And then we're going to establish a workflow, tasks around contacting those patients who are changeable, right? So a patient with a 100% no-show rate, for example, why would you schedule those appointments? As I said earlier, I mean, those we recommend treat them as a walk-in. Or talk to the patient and find out, why are you always no-showing? Is there something we can do to help improve that? Saturday clinics, for example, are a possibility. Or video appointments if you get stuck in traffic, so that we can do this non-face-to-face. On the other end of the scale, patients with a 0% chance of no-showing, there's no reason probably to contact them. They're reliable. They come. They cancel and reschedule if it doesn't work for them. So what we really want to do is identify those patients who would forget if they wouldn't get some kind of a reminder. So that's the small group of 2 or 3 people in my clinic for tomorrow that we want to make sure are called or reminded with a text. In addition, those high-value appointments, anything that's like a colonoscopy that's scheduled for 8 o'clock in the morning. Because if that patient doesn't show up, we don't have much of an opportunity to recover, to fill in, to use that time productively. On the other hand, if it's the 10 o'clock patient that doesn't show up, then we may have a chance to adjust, put a walk-in in there in the case of a primary care clinic, probably not an endoscopy clinic, but at least a primary care clinic, and do some adjustment as we go through the day. So the missed opportunity call list, or what we called the missed opportunity call list, which is part of the National Initiative to Reduce Missed Opportunities, which is what NIRMO stands for, that really became an important tool for clinics to really decrease their workload, in other words, only contact a few patients, and contact the ones who were the right patients for us. So that tool was paired with these strategies to decrease no-shows. And what we learned was no one strategy solved the problem. It really required a combination of strategies for clinics to reduce their no-show rates. Those strategies related to patient factors are listed here, along with system factors and logistics. I would just highlight a couple of things from this slide. First of all, if we don't have appointments, patients are going to be scheduled farther out into the future because we're booked into the future. And we know just because they're scheduled into the future, they're more likely to no-show. So developing a clinic that has white space in the future, where we can make just-in-time appointments, is a very strong strategy. That allows us to offer patients appointments at times that work for them, and it offers flexibility if they end up canceling and rescheduling appointments. So that, I would say, is at the top of my list for decreasing no-shows. Other things that I put under patient factors were offering different venues of visits. And I know in VA now we're offering a lot of video visits. I think we just passed 1 million here recently. Telephone visits, once you have an established relationship with the patient, if you don't need a physical exam or lab, you can do a lot of things over the phone. Even if you do need a physical exam or lab, those things can be scheduled at other times or done asynchronously. Electronic consults, where we can send the patient's chart to a specialist, and the specialist can look things over and answer the question of the referring or sending provider, is a good way to advance the decision-making and the next step of care for patients without having to make an appointment. And one-time appointments, online appointments, those things are patient factors. Just-in-time scheduling, as I mentioned earlier, for the system, customizing the scheduling to knowing the individual's no-show history. And I think I would like to emphasize really the most important system factor in my mind are those scripts, that exceptional customer service and communication. Think of 2 scenarios here. Scenario number 1, the provider ends the visit by saying, hey, Mr. Jones, good to see you today. See you later. Walks out of the room. Leaves an order for a return to clinic appointment. Patient goes out to the desk, and the scheduler says, thanks for checking out. Nice to see you today. See you later. Or the line's too long and they can't get in. Now compare that in your mind to a scenario of the provider saying, hey, Mr. Jones, it's great to see you today. The next step in care that we discussed is to get another blood pressure check and blood test in 3 months. Is that okay with you? Would you like to come back in 3 months? And then you get a commitment from the patient, a verbal contract saying, yes, I do agree that that's the next step in care, and yes, I do agree I need to come back. Okay, great. I'm going to write an order and send you to the desk. Then the patient comes out of the exam room, bumps into the nurse. The nurse says, I hope your appointment went well. Do you know what the next step is? And the patient says, yes, I'm supposed to come back in 3 months. Great. Let me show you where the checkout desk is. Then the scheduler goes through the same thing. I see that the doctor wrote an order for 3 months. Is that still going to work for you? Yes. So we've had 3 verbal contracts here. And at that point, they work out the best time and date and make the appointment on the spot and discuss what kind of reminder that patient would like. So those things that are soft things that are done, especially for those patients that we predict have a high no-show rate, really have, in our experience, made a huge difference in decreasing this no-show rate from the 12% average that I mentioned before down in some cases to close to 0. And I have to say in my clinic personally, which is a small clinic, but patients that I've known for a long time, the no-show rate's essentially 0. Because we know patients, we call them, we get them in, we adjust, they let us know, they have verbal contracts. So it's very possible to really improve this. There's other system factors there that I won't call out specifically, but you can read them, along with transportation factors. Now, I want to say one word about that before wrapping up my part of this. Transportation sometimes people think of as the number one reason for no-show, and as we saw, it's not. It's number 3, and a little bit of a distant number 3 compared to the other 2. However, for those patients who are committed to riding a van or a bus or a train or taking a cab or in a big city where you can get clogging of the road or unexpected accidents, transportation is a huge deal. So for those patients, first of all, I think there's 2 things. Number 1, identify those patients who have transportation concerns. That's number 1. Number 2, if you have an open schedule, make attempts to schedule appointments that are coordinated with that transportation so that the scheduler is sensitive to that being an issue and specifically asks the patient, what the most convenient appointment is for them. Now, once we commit to an appointment that is coordinated with transportation, you also have to commit to staying on time in the clinic, because now if we're late, as providers, the patient could be late for their next opportunity for transportation. So keep in mind that this is kind of a deal. The patient says, yep, I'll arrive on time, and we say, yep, we'll stay on time in order to get you out on time. Other thing I would call out is early notification, not only of weather, but I think also when you have ill or sick providers. As soon as we know that there's going to be a weather issue or a provider issue, having a contingency plan where we call patients and notify them, text them, maybe a group text of some kind. You guys who do technology can help us with this, right? So that the earlier the notification, the better, especially starting with those patients who have the farthest to go or are the very first on the schedule. So it seems to me that some sort of algorithm that says, hey, you're first and you're close versus, hey, you're last and you're far, would result in an order of notifying patients as soon as we know something like this is going to affect the clinic. I'd like to just share this graph, which is one group's experience with the no-show rate. Nutrition is notoriously high no-show in VA. And you can see in the blue line here, this nutrition clinic started out around the 40% range, and then they started to incorporate these strategies and ended up with no-show rates down close to zero. So it's possible to make big changes in this just with some thought. In addition, I know many VA facilities have put around posters like this that encourage people to cancel or reschedule appointments and make sure that cancellation is easy so that there's one phone line that's answered by a human being that offers the patient an opportunity to reschedule and raises awareness among patients about the importance of no-shows. And finally, this point about combinations of strategies, this slide, which shows kind of on the left-hand side that there was not great provider interactions, patient didn't receive reminder calls or letters, and did not have a negotiated appointment, meaning, what's the best time for you, had a higher no-show rate than those people on the right-hand side of this slide that had all of those things. So we know that those implementation of those strategies certainly matters. So I'd like to just end with a suggestion for a no-show strategies checklist, kind of in the order of things that I would think about if I were king of the world. It'd be great to have all clinics that have open access, meaning white space in the future, flexible time to be able to make appointments close to when you want them, and to be able to cancel and reschedule those appointments to times that work for patients. Secondly, we have total control, I think, over our communication and our scripts within the clinic. It's just a matter of training and reminding and queuing up, and there's another probably digital opportunity, to remind employees about their scripts for interacting with patients around no-shows. And again, those scripts that create that verbal contract are much more powerful than a statement. For example, one way to say this is, hey, Mr. Jones, don't no-show. That's a statement, right? The other way, which is a verbal contract, is, hey, Mr. Jones, will you call us if you can't make it? And then the patient says yes or no. And when they say that, hopefully they say yes, then they're much more likely to call. I'm creating alternatives to face-to-face appointments when planning the next step in care. Making appointments that work for the patient with the no-show rate in mind. And again, this is a matter of displaying that to the schedulers and training them about how to differentiate patients with transportation problems, forgetting problems. No-show problems are always no-show. There's, different buckets of patients. We should treat them differently. And coordinating appointments with transportation. And finally, and probably very importantly, perform those live targeted reminder calls. We've found that automated calls don't work very well because patients block them at home. Perform live calls with an opportunity to reschedule and or text messages and or, in our world anyway, letters, or remind patients in whatever ways that they feel work the best. So that's an overview of no-shows. It's a critical place to put effort, and there's a lot yet to be known about this and a lot we can do to improve this area. Thank you very much. Greg, I'd like to hand it back over to you.
Thanks, Mike. Very interesting case study on how the VA has approached the challenges of patient no-shows. And now I'd like to turn the presentation over to Andy Reeder, who is Associate Vice President for HIPAA Privacy and Security for Rush University Medical Center. Andy?
Great, thank you. And thank you, Mike. That was a very interesting presentation about the no-show dilemma. And, when I thought about HIPAA and how it relates to no-shows, there are really 3 things that stood out to me in your presentation. And there were some areas that I thought to reemphasize. You mentioned patient factors, system factors, and logistics and transportation factors. And there were a number of things that would help reduce the no-show dilemma that have to do with communications, also with transportation, and alternative visits as well. So when you think about video and e-consult and phone. And that's where I think some of our HIPAA and privacy considerations come in. So I'll just touch on some of those. So on the slide that I have here now, I think communications was one of the first areas that you cited that really can have an impact in terms of reducing no-shows or managing no-shows. And we heard that no-shows happen for different reasons, but we use communications to help in that area for things like appointment reminders, handling cancellations, notifying us and patients. It's really a two-way communication about conflicts, and there are many special needs, special things that come up where a patient communication may need to happen either one way, like a text message, or two-way by email, phone, or video. And so when you think about things like appointment reminders, those have been recognized by the Office for Civil Rights as part of treatment communication. So it's an acceptable part of treatment communications. But how we handle it and how we handle the communications can become a regulatory concern. So I wanted to mention HIPAA, which is one that we most often think about in healthcare, but also the Telephone Consumer Protection Act, which is definitely has a major impact in terms of how we handle communications, including those automated communications that you mentioned. So first, a consideration around HIPAA is that you put a notice in your Notice of Privacy Practices for your facility. It's a required element, the Notice of Privacy Practices that all patients receive, especially at their first visit to a facility, but that you outline in the notice that you will be sending appointment reminders and mention the type of reminders that you would send, whether it's email, voice, and that you'll be leaving voicemail messages, for example, text messaging, or other things like postcards or other things that could come up. This puts the patient on notice and gives them an opportunity to opt out of having that communication occur. Patients have the right under HIPAA for confidential communication. So if this is something you've notified them about and they desire not to participate, they can let you know in advance. In terms of using phone and email, it's very important to make sure that we've captured the patient's phone information and their email information correctly. It basically becomes an implied consent, especially under the Telephone Consumer Protection Act, to notify the patient using that method in terms of things like appointment reminders or appointment cancellations. So have the patient verify their contact information regularly at every visit. That's a common thing that would happen at patient registration. And have them let you know what their preferred method of being contacted in and give them an opportunity to opt out of any communications at that registration point. We have to respect those preferences going forward. And then also that capturing that information accurately is critical, because if we don't capture it accurately, it can lead to misdirected communications that can quickly lead to a privacy incident or a privacy breach downstream. When sending out information to our patients, obviously we want to send only necessary information. And that's another area where we need to look at those scripts that Mike mentioned, look at the things that we're actually automating or by phone to make sure that we're leaving out things like condition-specific appointment types, be as generic as possible, and also make sure that it's okay, for example, to let somebody know about an annual exam versus something that's very sensitive. So we have to be careful in terms of the information that we're actually providing over those communications means. Make sure that in your design of your communications that you're considering and minimizing the chances of misdirection. As I mentioned, misdirected information can quickly become a privacy incident or a privacy breach. And very importantly, your providers of your communications, oftentimes they will be hosting patient databases for you as a covered entity. So you want to make sure that you not only have the contract, but a business associate agreement with the provider of those services. And that'll be the number one thing, or one of the top things that's actually looked for if an institution is ever audited by the Office for Civil Rights, or if there's ever a privacy incident that occurs. In terms of the Telephone Consumer Protection Act, it's probably an area that is often not thought about, but is very critical to a healthcare institution. It's probably most thought about in terms of other industries like marketing and other kinds of communications, but has become very important for healthcare as well. It does provide certain exemptions for certain types of healthcare-related messages, but when we're sending messages to patients, especially automated messages, we have to make sure that we're providing an opt-out capability. The opt-in can be implied based on providing their information at registration, but the opt-out, if I don't want to receive text messages anymore, my messaging should provide that. I also want to mention that when there are concerns or issues that come up, that it's not always HIPAA or TCPA, but sometimes there are also state regulations that come into play, especially in the case of a privacy incident or a privacy breach. So an institution does need to know the laws of their state or states, depending on how large they are, to know how to handle that both at the federal and state levels. Some other privacy considerations are if you do have that misdirected text or email, to know that it needs to be reported internally right away so it can be investigated. So training frontline staff is very important. I often feel in this area, and when we're thinking about no-shows, the front desk staff is the most critical in my mind because they're dealing with on-the-spot, difficult situations every minute of every day. They're under a lot of pressure. So letting them know and doing some training on where to report problems is important. And developing scripts like we heard about before of how to deal with patients on the phone and how to deal with families on the phone is equally as important. How to know how to handle situations when a patient calls or when their representative calls or when somebody who isn't their representative calls. And we don't want to disclose information to somebody who's not authorized. So that should be part of the HIPAA scripting and training that occurs. Another area that we heard of in Mike's presentation was around transportation and helping sometimes with transportation to help minimize the no-show problem. Scheduling by the patient is probably not as big of a problem from a HIPAA standpoint, although they'll be scheduling it on their own, obviously. But when a driver shows up or somebody shows up at the facility, it's okay if they ask for somebody by name to let them know that you'll go contact that person and bring them out, for example. But depending on the patient's wishes or the sensitivity of the situation, you may not be able to bring them to the patient. So there are some things that will have to be thought out and scripted in advance. Clinicians obviously have to use their professional judgment to help the patient, but we have to think about how we handle the privacy in that situation as well. In terms of the facility scheduling, more and more we're starting to see ride-sharing services and other services that are actually scheduling these activities for patients and for facilities. And so you want to make sure that you have a business associate agreement in place with that particular service so that they can handle that information appropriately. And then finally, in terms of alternative visits, we thought about a few different kinds: video, e-consult, a phone, if a patient can't actually come on site. So depending on the type of alternative visit being considered, there typically would be required a consent for the patient to be recorded or to use that type of electronic communication. We would want to make sure that the recordings and the notes that are being obtained are actually entered into the medical record. So there's going to be a way to enter that into the medical record. The recordings and the notes all need to be protected for privacy and security reasons under HIPAA, just like written or digital notes as well. And ensure access is audited or auditable and disclosures are protected just like other parts of the medical record. The vendors that are hosting these services, obviously there's security controls to be assessed, and then contracts and business associate agreements put in place under the HIPAA security rules. So there are many considerations that need to be taken, not only in terms of communicating with the patient, but in terms of the vendors that we're using to host the services that we're using with our patients. Greg, I'll turn it back to you.
Thanks, Andy. And as we heard loud and clear from your presentation, HIPAA compliance is critical. And now we have our final speaker, Mark Tressiter from Progress, our sponsor for today's webinar. He is president of strategy at Progress, and he focuses his time on meeting customers and assisting in product and go-to-market strategy. Mark?
Thank you, Greg. It's our pleasure to sponsor today's webinar, and we feel the information that Mike and Andy shared is invaluable in this time of rapid change within the healthcare industry. A little bit about Progress. We are a longtime leader in helping organizations build and support application and digital experiences. We are most proud about the impact our products and solutions have on the market. You can see a few of the numbers as we work with a large number of ISVs, corporate accounts across key verticals like healthcare, financial services, and manufacturing, and have a global presence when it comes to the number of developers that use our products and the number of end users that benefit from app experiences that are made possible by Progress. And we know the type of experiences required are changing. Given mobile, social, and 24/7 connectivity, patients as well as providers and life science professionals demand a great user experience, something which Greg, Mike, and Andy both talked about. And that experience needs to transcend any specific channel, such as phone, tablet, chat, conversational, and more, whether it's e-consults or video visits as well. Specific to healthcare and the topic of today's webinar, we help organizations reduce patient no-shows with predictive powers of AI and machine learning. We utilize internal practice data and external factors like weather, time, and date to create probability heat maps for patient scheduling. This capability is integrated into the application in the form of strategic recommendations to help minimize loss and maximize practice revenue. The Progress Health Cloud is HIPAA compliant, so you can trust that patient health information is securely collected and shared across the continuum of care. It is hosted in the cloud so that you can centralize your data governance with the scale and capacity needed to apply analytics to your strategic decision making. And it provides the flexibility and interoperability necessary to achieve your health outcome goals, including the ability to improve the patient-provider experience, drive operational efficiencies, and reduce clinical inefficiencies. We'd be happy to arrange a conversation with one of our digital experts. Just reach out to us via the email that is on the bottom part of the screen. And thanks to Mike and Andy for today's excellent presentation, and thank you for attending. And back to you, Greg, for Q&A.
Thanks, Mark, and thanks to Mike and Andy as well for an informative discussion on an important and timely topic. We've now reached the Q&A portion of today's webcast, and we've got a number of questions in the queue that we'll get to momentarily. I just want to remind the audience, if you want to submit a question, to look for the Ask a Question console and submit a question that way. And now let's get to our first question from the audience. Mike, this is for you. Member of the audience is interested in your analysis that revealed that males had higher no-show rates than females, and that later males and females exhibited similar rates, with the average no-show rates decreasing with age. Is that a finding that played into the VA strategy to reduce no-shows? And if so, how did they approach this gender age issue?
Right. Thank you for that question, and that's a good question. Remember, what we did in the study was we looked at no-shows as the dependent variable and then looked at a number of independent variables to understand the problem, better. Sort of like trying to feel different parts of the elephant and put it all together. And so when we looked at overall men versus women, it was clear that men no-showed the most, especially if they were in the younger age groups, as you saw on that slide. However, when we looked at it through the lens of appointment age, how old is an appointment? In other words, what's the elapsed time between when an appointment was created in the system and when it was completed, that appointment age? What we found was men and women are pretty similar. Men were maybe slightly higher, but through that lens, there was a huge impact of appointment age on the chances of no-show. So in the final predictive model, we weighted the various factors so that the prediction, the chances of a patient no-showing in the future, took into account really all of the variables. Now, the question you asked about strategies was harder, I think. I think we try to train schedulers to customize their conversation with patients to some extent, looking at their chances of no-shows. I think personally that all organizations struggle with schedulers turning over a lot, and so you end up with new people all the time, which is good in that we have a chance to train those people in a fresh, way, but requires a continual burden of training. So I'm less optimistic myself at how well training sticks, compared to a strategy like the missed opportunity tool that's able to account for those factors objectively and systematically every time. And I think the more that we get smart about incorporating those strategies into actions that we know happen, the better we'll be. For example, why not, should we contact patients once or twice? How long before the appointment should we contact them? Should we contact them all? Or should we contact a subset of them? Are some patients really needing a phone call and a reminder? Or for people who are really ill, mental health patients, should we send a cab after them? Should we see them in another venue? And I know that's an issue in the VA world, as you might imagine. So there are many, I think, potential strategies, and I think looking at it through the lens of age and appointment age and age of the patient are two, but there's a lot to learn in this area. Greg?
Thanks for that, Mike. And we're quickly running out of time. I want to get in a question here we have for Andy. This one regarding business associate agreements. So you mentioned BAAs. Are there particular areas regarding BAAs that providers need to be mindful of when it comes to putting together patient no-show strategies?
Yeah, great. Good question. And a business associate agreement is a requirement under the HIPAA security rule. If a vendor is hosting or processing PHI, protected health information, for a covered entity, like a hospital, for example. So the main thing that really needs to come into consideration are what are the requirements and needs. So that's basic negotiation with a vendor, for example, between the business, between the IT group, and legal affairs and compliance. Sometimes those are the groups that really need to get together to determine what are the requirements that need to be placed into the contract, and then the business associate agreement becomes the second part of the contract that needs to be, we'll say, negotiated, although typically it's a template. So the key thing is that an institution needs to discuss with their legal affairs what's required, and then have those things signed. Third-party risk is a major area these days for facilities around security controls. So you've got to dig into what are the security controls that a vendor has, make sure that's transparent, that it's been assessed, that perhaps there is an audit or an attestation, like a SOC report, that can be used, and then make a determination that it's acceptable so that a BAA can be signed. But that BAA is critical. Thanks, Greg.
Well, thanks, Andy, and appreciate it. Mike and Mark, appreciate your participation today. Unfortunately, we're going to have to leave it there. We've reached the conclusion of today's webcast. I want to thank Progress for sponsoring today's event, and of course I want to thank the audience for joining today. For those members of the audience that have submitted questions that were not answered, you will receive a response. So again, thank you very much for attending, and this concludes today's webcast.